Operative treatment. In the absence of complications specifically requiring operations, such as intractable stricture or abscess, it is, generally speaking, unwise to operate upon cases of chronic urethritis. Intractable cases of prostatic neuralgia have been cured by scraping the posterior urethra, but such a treatment would seem more likely to do harm than good in most cases. Young advises prostatectomy for the treatment of chronic prostatitis, but his best results are obtained in cases of retention, and it is obvious that retention from prostatic bar or contracture in a young man requires the same operative treatment for its cure as does prostatic retention in the aged. Dilatation does these cases no good. Operations for the relief of vesiculitis. The operative relief of infections of the seminal vesicles has been attempted in two ways, by drainage through the vas deferens and by direct operative attack upon the vesicle itself. Bellfield's operation. Bellfield picks up the vas in the scrotum, incisors it after local infiltration of the skin with cocaine, injects the proximal end of the duct with 10% argyrol or 4% cholergol, and fixes the duct in the wound so that any reflux of the fluid injected will issue from the wound itself and not flow into the subcutaneous tissue, there to cause an irritative phlegmon. He hopes thus to obtain both antisepsis and drainage of the vesicle. Edema around the little wound interferes with subsequent injections. Excellent results have been reported from this operation, and it is believed that if the vas is not completely divided, or if it is brought together again by a single catgut suture so that the two ends are opposed to each other, occlusion of the vas does not occur. Contrary to what one would expect, experiments seem to bear out this statement. Thomas has suggested that the injection be made through a needle puncture of the exposed vas. This readily finds the lumen and supplies antisepsis without drainage. Whatever form of operation is employed, care must be taken not to infiltrate the tissues about the vas. The operation is simple enough. In my hands, it has been quite without effect, excepting in a few cases of recurrent epididymitis. I am inclined to suspect that the benefit in these cases has been due to occlusion of the vas at the point of operation. Vesiculotomy and Vesiculectomy. The direct attack upon the vesicle is much more successful, both for the relief of rheumatism and of pain. Most authors employ vesiculotomy through Cabot, believing that no simple incision can really drain such a complicated tube as the vesicle, has employed vesiculectomy. The operation unquestionably relieves the rheumatic pain of a large class of patients, but it fails in a totally indeterminate number of cases. When vesiculotomy fails, vesiculectomy combined with prostatectomy may succeed, though even this does not guarantee a cure. The operation has been applied to a very loosely classified type of painful cases. Its value in the treatment of these is open to doubt. I have employed it several times with no success. In the acute stages of gonorrheal rheumatism, it is likely to prove brilliantly successful, but many of these cases are readily relieved by other means. Therefore, the operation is usually reserved for intractable cases, the majority of whom it cures. It does not, however, protect the patient against a relapse if he becomes reinfected with gonorrhea. Impotence follows vesiculotomy in a very small percentage of cases. It is a common result of vesiculectomy. I have operated upon but very few cases and with no resulting impotence.